Hello, welcome to the Medical Assistant Emerson channel. So today we are going to go through the arterial blood gas interpretation part 3, where we'll go through 11 worked scenarios. Okay, so if you haven't subscribed, please subscribe and hit the bell notification. And if you haven't watched part 1 and 2, then you have to watch them before you watch this part 3. Good part 1 and part 2 has been combined, so this is just part 3, but it's just a second video we have posted on the channel. So please watch part 1 and part 2, which have been combined previously. Okay, so question 1 is saying a 17-year-old patient present to the A&D complaining of a tight feeling in their chest and shortness of breath and some tingling sensation in their fingers and around their mouth. They have no significant past medical history and are not on any regular medication. So the ABG was performed on the patient who is not currently receiving any oxygen therapy. So the ABG which was performed reviews the following. So there was a patch pressures of 14 and 14 kilopascals. Then the millimeters of mercury was 105. Okay, so we are giving both in kilopascals and millimeters of mercury. And then there was a pH of 7.49, and there was a partial pressure of carbon dioxide of 3.6. Then in terms of millimeters of mercury, it was 27. Then the bicarbonate levels was 24, and of course the reference ranges has been given. So let's break them down. So the partial pressures of oxygen, which is oxygenation, was 14 on room air, and which was at the upper limit of normal. So the patient is not hypoxic, but you can say the patient at least there is some hyperventilation that is going on. Okay, then the pH was 7.49, and it was higher than normal, and therefore the patient is alkalotic. Okay, so the next step is now to figure out whether the respiratory system is contributing the alkalosis or not. Okay, so that's what we have to figure out. So is this contributing to the alkalosis or what? So if it's contributing to the alkalosis, we have to expect the pressures of carbon dioxide to be reduced. Then it is contributing to the alkalosis. So the partial pressure of carbon dioxide in this case is low, which would be in keeping with an alkalosis. So we know that the respiratory system is definitely contributing to the alkalosis, if not the entire cause of it. So next thing we are going to do is we are going to look at the bicarbonate levels and see if it is also contributing to the alkalosis. So the bicarbonate levels is normal, which rules out a mixed respiratory and metabolic alkalosis, leaving us with an isolated respiratory alkalosis. So in terms of compensation, there is no evidence of metabolic compensation of the respiratory alkalosis, which would involve a lowered bicarbonate. So if there was metabolic compensation, there would be a lowered bicarbonate, suggesting that this derangement is relatively acute, as metabolic compensation involves or takes a few days to develop. Then in terms of interpretation, this is a respiratory alkalosis with no metabolic compensation. So the underlying cause of respiratory alkalosis in this case is a panic attack. So with hyperventilation in addition to peripheral and perioral tingling being classical presenting features. So that's the end of question 1, and how we have interpreted it. So we move on to the next question. So this is question 2. So question 2 says a 16-year-old female presents to the hospital with drowsiness and dehydration. They have no previous past medical history and are on no regular medication. And an ABG is performed on room air that reveals the following. So there is a partial pressures of 14 kilopascals and meters of mercury over 105. So you might be, so in short, what we are just talking about here is that you might be given either one, or you still might be given both, so that if you maybe you know the one in kilopascals, you are covered. You know the one in millimeters of mercury, you are also covered. Then the pH is 7.33. Then the partial pressure of carbon dioxide is 3. And then in millimeters of mercury, it is 22.5. And the bicarbonate levels is 17. Okay, so how do we break them down? So of course we start with oxygenation. So we look at the oxygenation. So the partial pressures of 14 on room air is at the upper limit of normal, so the patient is not hypoxic. Then a pH of 7.33 is lower than normal, and therefore the patient is acidotic. So the next step is to figure out whether the respiratory system is contributing to the acidosis. Okay, that is if there is increased carbon dioxide. Okay, so the partial pressure of carbon dioxide is low, which rules out the respiratory system as the cause of the acidosis, as we would expect it to be raised if this was the case. Okay, but in our case it is low, so meaning it's not contributing to the acidosis. So we now know the respiratory system is not contributing to the acidosis, and this is therefore metabolic acidosis. Okay, so how do we move on, since we now know that the respiratory system is not contributing to the acidosis, and this is therefore a metabolic acidosis? So the next step is to look at the bicarbonate. So we need to confirm that what we have said, that this is a metabolic acidosis, is actually true. Okay, so you look at the bicarbonate. So the bicarbonate is low, which is in keeping with the metabolic acidosis. So then about compensation. So we now know that the patient has a metabolic acidosis, and therefore we need to look back at the carbon dioxide to see if the respiratory system is attempting to compensate for the metabolic derangement. So in this case, therefore, there is evidence of respiratory compensation, as the carbon dioxide has been lowered in an attempt to normalize the pH. So the carbon dioxide has been lowered in an attempt to normalize the pH. Okay, so an important point to recognize here is that although the derangement in pH seems relatively minor, this should not lead to the assumption that the metabolic acidosis is also minor. The severity of the metabolic acidosis is masked by the respiratory system's attempt at compensating via the reduced carbon dioxide. Okay, so in short, what we are talking about, the pH of course was low, but the carbon dioxide levels were also low. So the carbon dioxide levels were low because of respiratory compensation, so that they try by all means to bring back the pH to normal levels. Okay, so in terms of interpretation, this is a metabolic acidosis with respiratory compensation. Okay, so if you ask the underlying cause, then you would say the underlying cause of metabolic acidosis in this case is diabetic ketoacidosis. Looking at the clinical picture we have been given and the signs and symptoms, they are in keeping with diabetic ketoacidosis. Okay, so let's move to the next question. This is question 3. Okay, so you are asked to review a 63-year-old female who was admitted with shortness of breath. Then on your arrival, the patient appears drowsy and is on 10 liters of oxygen via a mask. Then you perform an ABG, which reviews the following results. So the partial pressures of oxygen were 7.0 kilopascals, and in millimeters of mercury they were 52.5. Then the pH was 7.29. Then the partial pressure of carbon dioxide was 9.1 kilopascals. Then in millimeters of mercury it was 68.2. Then the bicarbonate levels were 26. Then the base excess was positive 1. Okay, so still need to break them down. So in terms of oxygenation, the oxygenation is low, so we know that the patient is in respiratory failure. However, we don't yet know what type exactly we are dealing with. So the pH, so by type we mean whether it's type 1 or type 2. But the pH, you should then note that the pH reveals an acidosis and assess the carbon dioxide to see if it is contributing to the acidosis. So we know that the pH is so the pH is 7.29, so meaning it reveals an acidosis. And so the next thing you have to assess if the carbon dioxide if the respiratory system is contributing to the acidosis. So in this case, the partial pressure of carbon dioxide is raised significantly, and this is likely to be the cause of the acidosis. But in the context of a low partial pressures of oxygen, a raised partial pressure of carbon dioxide suggests that the patient has type 2 respiratory failure. So in short, in this case, the patient has a raised significantly partial pressure of carbon dioxide, and this is most likely causing a acidosis. Okay, then if the low partial pressures of carbon dioxide and the raise would suggest a type 2 respiratory failure. So we are saying the patient is hypoxic and they have hypercapnia. Okay, so hypercapnia. So this means that the patient has respiratory failure type 2. Because if it was type 1, then there would have been normal capnia. Okay, so we move on to the next section where we look at the bicarbonate levels, which of course is normal. So the metabolic system is not contributing to the acidosis and also isn't compensating for the respiratory acidosis, suggesting that this is an acute derangement. Okay, then the best excess is within normal limits, as there has been no significant change in the amount of bicarbonate. And then if this respiratory acidosis was chronic, we would expect that the kidneys would have generated more bicarbonate to compensate, which would have resulted in an increased base excess. Hope we are together. And then interpretation. So this is a respiratory acidosis. Then the respiratory acidosis has been caused by type 2 respiratory failure, the failure of ventilation, leading to increased levels of carbon dioxide. So there is hypercapnia. That's what we were talking about. So that's the thing you have to know about that question. Then let's go to question 4. So question 4 says the 48-year-old male has been admitted with a 24-hour history of abdominal distension and profuse vomiting. The CT scan reveals a large mass causing bowel obstruction. As part of the patient's assessment, the surgical registrar suggests that you check for his blood gas on air, then with the results shown below. Okay, so he has a partial pressures of 12 point partial pressures of oxygen of 12.7 kilopascals. And then in terms of millimeters of mercury, it is 95.2. Then the pH is 7.5. Then partial pressures of carbon dioxide is 5.5 kilopascals. Then in millimeters of mercury, it is 41 millimeters of mercury. Then the bicarbonate is 29, and the base excess is positive 3. Okay, so in this case, we have a lot of things to talk about. So just know that the oxygenation in this case is 12.1 on air, which is normal. So the patient is not hypoxic. Okay, so the patient is on oxygen and has a raised and as that as that partial pressure, so it is still normal. Okay, and the pH of so a pH of 7.5 is higher than normal, and therefore the patient is alkalotic. So the next step is to figure out whether the respiratory system is contributing to the alkalosis. So if it is contributing to the alkalosis, there should be a reduced carbon dioxide, partial pressures of carbon dioxide. Okay, so the partial pressure of carbon dioxide is normal, which is not in keeping with an alkalosis. So we now know the respiratory system is not the cause of this derangement. So the next step is to look at the bicarbonate levels to see if it's going to explain the alkalosis. So the bicarbonate levels is high, which is in keeping with the metabolic alkalosis. And the base excess is increased, which is also in keeping with an excess of bicarbonate levels. In terms of compensation, so the respiratory system can attempt to compensate for metabolic alkalosis by increasing the partial pressure of carbon dioxide, so decreasing ventilation. But in the short term, the respiratory system will likely maintain partial pressures of carbon dioxide within the normal range. So if the metabolic alkalosis persists, however, you would expect the partial pressure of carbon dioxide to rise and compensate for the metabolic alkalosis as the respiratory centers become progressively desensitized to the increasing levels of carbon dioxide. That's why we have talked about the compensation. Okay, so interpretation of this scenario is that this is a metabolic alkalosis, and you have to remember as a result of this patient's profuse vomiting, they have lost significant amounts of hydrochloric acid, so which is the stomach acid as we know it. Then the parietal cells then are going to produce more carbonic acid in response, and the hydrogen ions are then transported into the stomach to replace what was lost. Then the remaining bicarbonate is transported into the blood, resulting in an increase in free bicarbonate levels. So that's what you need to know here. Okay, so hope we are together. Let's move on. In addition, as a result of vomiting, the patient's volume is depleted, which results in the release of aldosterone and other mineralocorticoids, which in turn increase the bicarbonate reabsorption by the kidneys, further increasing the amount of free bicarbonate in the serum. So that's the addition. Okay, then for question 5. So question 5 says or reads, you are asked to review a 59-year-old female who has been admitted in the acute medical ward for your hospital. Then the nurse tells you that she appears short of breath despite currently receiving 3 liters of oxygen via nasal cannula. Then you take an ABG which reveals the following results. The partial pressures of carbon dioxide is 9.1 kilopascals, and in terms of millimeters of mercury it is 68.2. Then the pH is 7.3. The partial pressure of carbon dioxide is 8.4. Then in terms of millimeters of mercury it is 63. Then the bicarbonate levels is 29, and the base excess is positive 4. Okay, then the answer for oxygenation is that or how we break them down. So the oxygenation, you have to know that the partial pressures of 9.1 kilopascals is low, confirming that the patient is hypoxic. Then it is important to recognize that this partial pressure of oxygenation is much lower than you would expect for a patient on 3 liters of oxygen. So an oxygen flow rate of 3 liters via nasal cannula would be expected to deliver an inspired concentration, which is the FiO2, the fraction of inspired O2, of around 32%. And therefore, we would expect that the partial pressures of oxygen would be approximately 10 kilopascals less than this. So, if, for example, it should be at least 22 kilopascals or not 2. But the partial pressure of 9.1 is therefore grossly abnormal and indicates significant hypoxia. Okay, so in terms of the pH of 7.3 is lower than normal, and therefore the patient is acidotic. So the next step is now to figure out whether the respiratory system is contributing to the acidosis. So, e.g., there should be increased carbon dioxide. So in this case, the partial pressure of carbon dioxide is raised significantly, which is in keeping with an acidosis and also type 2 respiratory failure. So we know that the respiratory system is likely the cause of this derangement, or at least a contributor. So the next step is to look at the bicarbonate levels and see if it is contributing to the acidosis. Okay, so the bicarbonate levels is of course high, which is not in keeping with an acidosis. So the metabolic system is not contributing to the acidosis. In fact, the raised bicarbonate is compensating for the low pH. So the raised bicarbonate is compensating for the low pH. So in terms of base excess, the base excess is increased, which is in keeping with an excess of bicarbonate levels. Okay, so in terms of compensation, there is evidence of metabolic compensation as the bicarbonate levels is raised significantly. Then interpretation, this is a respiratory acidosis with metabolic compensation, and you have to note that the patient, if you ask the diagnosis, the patient has COPD from the clinical pictures we have been given, and from the ABGs that we have found. So the patient has a chronically elevated level of carbon dioxide. As a result, the metabolic system has had time to compensate via the generation and retention of bicarbonate levels to oppose further decrease in pH. So this explains why the pH is only slightly acidotic despite a significant raised partial pressure of carbon dioxide. Because if this derangement in carbon dioxide was acute, there would not have been time for a compensatory response from the metabolic system. Hope we are together. In terms of question 6, so for question 6, the patient who has come in is a 9-year-old patient who presents with fever, rigors, hypotension, and reduced urine output. They appear confused and are unable to provide any meaningful history. The carers at home that says that the patient came from the care home that the patient came from has provided some basic documentation, and you look through the information available and note that the district nurse changed this patient's catheter 24 hours ago. So the medical registrar commences antibiotics and aggressive fluid resuscitation and asks you to perform an arterial blood gas. With the results shown below, the patient was not on oxygen at the time of the ABG. Okay, so the partial pressures of carbon dioxide was 12.4 kilopascals, and in terms of millimeters of mercury, it was 93. Then the pH was 7.29. Then partial pressures of carbon dioxide was 5.5 kilopascals. In terms of millimeters of mercury, it was 41.2. Then the bicarbonate levels was 15, and the base excess was -4. Okay, then let's break them down. So in terms of oxygenation, the oxygenation of partial pressure of oxygen of 12.4 is normal, ruling out hypoxia as the cause of the respiratory of the patient's confusion. Then a pH of 7.29 is abnormally low, and therefore the patient is severely acidotic. So the next step is to figure out whether the respiratory system is contributing to the acidosis. So in short, there should be an increased carbon dioxide. So if you're following the trend, so the pH, when the pH is low, the carbon dioxide is raised. When there is respiratory contribution to the acidosis, that's what we are talking about. Okay, so so the partial pressures of carbon dioxide in this case is normal, and therefore the respiratory system does not appear to be contributing to the acidosis. So the next step is to look at the bicarbonate and see if it is contributing to the acidosis. Okay. Then for the partial pressures of carbon dioxide is normal, and therefore the respiratory system doesn't appear to be contributing to the acidosis as well, so it is also normal. Then the next step is to look at the bicarbonate and see if it is contributing to the acidosis. The bicarbonate levels is low, which is in keeping with an acidosis. So the metabolic system is the cause of this patient's acidosis. Okay, then in terms of base excess, the base excess is low, in keeping with the diagnosis of metabolic acidosis. Okay. Then in terms of interpretation, we can conclude that the patient has a metabolic acidosis, and we have to note that the likely diagnosis, if we were asked the likely diagnosis, then it would be urosepsis, likely given the clinical presentation and the history of recent catheter change. So this patient has presented profoundly septic, with fever, hypotension, and evidence of reduced end organ perfusion, such as the reduced urine output. Then reduced end organ perfusion causes tissue hypoxia, resulting in cells resorting to anaerobic respiration to generate energy. Then anaerobic respiration produces lactic acid as a byproduct, which has resulted in the addition of acid to the patient's serum, causing lactic acidosis. So that is the explanation for what has happened to the patient using the ABG and the clinical picture that we have been given. Okay, so let's move on to the next station or question rather. Then the question says a 22-year-old female is brought into the A&D by ambulance with a 5-day history of vomiting, okay, and lethargy. When you begin to talk with the patient, you notice that she appears disoriented and looks clinically dehydrated. At present, you are unable to gain any further details, but the patient looks very unwell. Then from the end of the bed, you gain IV access and send off a routine panel of bloods and commence some fluids. And you ask the nurse, okay, to check the patient's observations, and she notes an increased respiratory rate, low blood pressure, and tachycardia. You perform an ABG on the advice of your registrar. Then the results of the ABG were shown below. So the patient was not on oxygen when this was taken. So the first pressure of oxygen was 13 kilopascals, and in terms of millimeters of mercury, it was 97.5. And the pH was 17.3. That was the pH. The partial pressure of carbon dioxide was 4.1 kilopascals, and in terms of millimeters of mercury, it was 30.7. Okay. Then the partial pressures of bicarbonate was 13. Then the base excess was -4. Okay, then in terms of breaking them down, so you can say in terms of oxygenation, the partial pressure of oxygen of 13 kilopascals is normal, ruling out hypoxia as the cause of the patient's confusion. Then a pH of 7.3 is abnormally low, and therefore the patient is acidotic. The next step is to figure out whether the respiratory system is contributing to the acidosis. So meaning if there is increased carbon dioxide, okay, then the pH is going to be, then the respiratory system would be contributing to the acidosis. But the partial pressure of carbon dioxide is actually low, and therefore the respiratory system doesn't appear to be contributing to the acidosis. So the next step is to look at the bicarbonate levels and see if it is contributing to the acidosis. So the bicarbonate in this case is low, which is in keeping with an acidosis, and so the metabolic system is the cause of the patient's acidosis. Then the base excess is low, which is also in keeping with the metabolic acidosis as well. Then compensation, so there is evidence of respiratory compensation for this metabolic acidosis. So what has been given from the respiratory compensation is that the partial pressures of carbon dioxide are low. So there is some form of compensation from the metabolic system. Okay, so there is reduced levels of carbon dioxide levels. Okay, so in interpretation, there is metabolic acidosis with respiratory compensation. That is the interpretation. So for question 8, the question says a 56-year-old man was found unconscious at home with a respiratory rate of 6 breaths per minute and a pinprick pupils, and an ambulance was called and the paramedics administered some naloxone on arrival to A&E, and this ABG showed the following. So this was the patient was not on oxygen at the time of the ABG. So the partial pressures of oxygen were 7.9, and in terms of millimeters of mercury, they were 59. Then partial pressures of pH, the pH, so the pH was 7.31. Then the partial pressure of carbon dioxide was 7.1, and in terms of millimeters of mercury, it was 53. Then the bicarbonate levels was 22, and the base excess was positive 1. So let's break them down. So oxygenation of 7.9 is low, so we know that the patient is in respiratory failure, but we need to know the carbon dioxide so we can know which type of respiratory failure. So we need to know whether we are dealing with respiratory failure type 1 or type 2. Okay, but the pH is abnormally low as well, and therefore the patient is acidotic. So we also need to figure out whether the respiratory system is contributing to the acidosis. For example, when there is increased carbon dioxide. Okay, so the partial pressure of carbon dioxide is high, and therefore the respiratory system is contributing to the acidosis. So given the low partial pressures of oxygen, we can say that this gentleman has type 2 respiratory failure. So low partial pressures of oxygen and raised partial pressures of carbon dioxide. So we have hypoxia and hypercapnia. So the next step is to look at the bicarbonate levels. So bicarbonate levels is within the normal range. So given the relatively fast onset symptoms, there would not have been a metabolic compensation. So the base excess is also within the normal range. Again, there is no metabolic compensation. So interpretation, the patient has a respiratory acidosis with type 2 respiratory failure. Okay. Then you have to note that the history suggests that this man has taken an overdose of opioids, given the reduced level of consciousness, respiratory depression, and pinpoint pupils. Then the respiratory depression has led to hypoxia, hypercapnia, and ultimately respiratory acidosis. Then question 9. Okay, question 9. We have a 77-year-old lady who was admitted to the hospital 10 days ago with a fractured neck or femur. Then the orthopedic team repaired the fracture and she has been an inpatient on the orthopedic ward, recovering ever since. The patient's nurse is becoming increasingly concerned as the patient's oxygen requirements are increasing. So she's now on 3 liters of O2. And the patient is now tachypnic, respiratory rate 35. In addition, the patient has recently started complaining of calf pain. You review the patient and they perform an ABG which reviews the following. The patch pressure of oxygen is 6 kilopascals. Then in meters of mercury it is 45. Then the pH is 7.51, and the patch pressures of carbon dioxide is 3 kilopascals, and in millimeters of mercury it is 23.2. Then the bicarbonate is 21, and the base excess is 0. Okay, so let's break them down. So oxygenation, so 3 liters of 3 liters of oxygen is equivalent to 32%. So therefore expect a patch pressures of approximately 22 kilopascals for a patient on this level of oxygen. So the patient who is on O2 and has a patch pressure of oxygen of 6 kilopascals is therefore very low. Then the pH of 7.51 is abnormally high, and therefore the patient is alkalotic. Then the next step is to figure out whether the respiratory system is contributing to the alkalosis, e.g. when there is reduced carbon dioxide. So the patch pressure of carbon dioxide is low, and therefore the respiratory system is contributing to the alkalosis. Okay. Then the next step is to look at the bicarbonate levels. So the bicarbonate levels is within normal range. So the metabolic system is not compensating to the alkalosis and also isn't compensating for it. Then the base excess is within normal range. Again, there is no metabolic compensation. So interpretation, this is just a respiratory alkalosis and type 1 respiratory failure. So you have to note that from the clinical history, this patient may have a deep vein thrombosis and as a secondary pulmonary embolus. So this has resulted in an increased oxygen requirement. So the patient is likely hyperventilating to maintain their oxygenation level, but as a result is exhaling excessive amounts of carbon dioxide, leading to alkalosis. Okay, hope we are together so far. Then for question 10, it says a 24-year-old medical student has just returned from his elective in Zambia, and in the last few days, he has developed severe diarrhea and has now presented to the accident and emergency. Then on assessment, he is very dehydrated and tachypnic. An ABG is performed and reveals the following. Patch pressures of oxygen was 14.6 kilopascals. Then in meters of mercury, it was 106.9, 109.5. Then the pH was 7.32. The patch pressures of carbon dioxide was 4 kilopascals. In meters of mercury, it was 30. Then the bicarbonate level was 13, and the base excess was -4. Okay, then let's break them down. So oxygenation, the patch pressures of 14.6 kilopascals is high, and this is likely due to hyperventilation. Then the pH of 7.32 is low, suggesting that this gentleman is acidotic. So we need to now look at the partial pressures of carbon dioxide to assess if this is contributing to the acidosis. So in short, there should be an increased carbon dioxide if it is contributing. So the partial pressure of carbon dioxide is low, and therefore the respiratory system is not contributing to the acidosis. In fact, with this low carbon dioxide, we could expect an alkalosis. So we need to consider if this is an attempt by the respiratory system to compensate for metabolic acidosis. So the next step is to look at the bicarbonate levels. So the bicarbonate levels is low, which is in keeping with our suspicion of metabolic acidosis. Then the base excess is low, which is also again in keeping with the metabolic acidosis. So interpretation, this is metabolic acidosis with a respiratory compensation. Then you have to note that the patient is losing bicarbonate levels through the gastrointestinal tract as a result of diarrhea leading to metabolic acidosis. Then the respiratory system is also attempting to compensate by blowing off carbon dioxide to create a respiratory alkalosis in an attempt to neutralize the acidosis and bring the pH back into the normal range. Okay, then this is the last question, which is question 11, which says a 64-year-old man is admitted to A&D with central crushing chest pain, and as the nurses are getting him attached to the ECG, he has a cardiac arrest. Thankfully, CPR was commenced immediately, and after 6 minutes, he regained spontaneous circulation and began breathing again. Then an ABG, which was done when the patient was on 15 liters O2, was performed following this sequence of events reveals the following results. So he has a partial pressure of oxygen of 9.5 kilopascals and a 71.3 millimeters of mercury partial pressures of oxygen. Then the pH is 7.14 and has a partial pressures of carbon dioxide of 8.1, and in terms of meters of mercury it is 60.8. The bicarbonate levels is 15.2 and the base excess is negative 9.7. Okay, so let's look at this. So in terms of, let's break them down. So in terms of oxygenation, the oxygenation is 9.5 on O2 and it is very low, particularly in the context of the 15 liters of O2. This suggests that the presence of an impaired ventilation likely secondary to the cardiac arrest. So the pH of 7.14 is low, suggesting that this gentleman is acidotic, and we now need to look at the partial pressures of carbon dioxide to assess if it is contributing to the acidosis. So it's meaning there should be an increased carbon dioxide if it is contributing to the acidosis. Then the partial pressures of carbon dioxide is high, which is in keeping with a type 2 respiratory failure and also in keeping with a respiratory acidosis. This is again likely to secondary to impaired ventilation. Then the next step is to look at the bicarbonate levels. So the bicarbonate level is low, suggesting that the metabolic system is also contributing to the acidosis. Then the base excess is also low, which is in keeping with the metabolic acidosis as well. Then interpretation is that this is a mixed respiratory and metabolic acidosis. You have to note that from the history and the results, the patient has had a cardiac arrest, which meant there was a period of impaired ventilation and then the organ perfusion. And then this has ultimately led to hypercapnia causing respiratory acidosis in addition to the accumulation of products of anaerobic respiration. So as a result of hypoxia and reduced organ perfusion, which caused the metabolic acidosis. So hope we have gone through almost most of the things we need to know, and this is the end of the part 3. And if you haven't subscribed, please subscribe and hit the bell notification. And of course, thank you for watching. and give us a like and comments, and also ask us questions that we may respond to. Okay, and if you haven't watched part 1 and part 2, please watch, and see you on the next tutorial video. And thank you for watching once again.